Hi, good evening, everyone. I'm Lix Oliveira, Chair of the CIED Artificial Intelligence Committee. Before we begin the program, I would like to ask for a minute of silence, specifically for the people and our friends in Venezuela who are suffering the consequences of the earthquake that caused widespread destruction and many deaths, but also for all those around the world suffering from war, hunger, and disease. 1 minute of silence. Okay, today's webinar was designed around the various questions we receive daily from other physicians regarding artificial intelligence. After all, any healthcare technology is only valuable if it ultimately benefits our patients. To that end, we have selected world-renowned experts in artificial intelligence to answer these questions. I would now like to invite Dr. Asadur from Uruguay, a familiar face to us all, the current president of the World Endoscopy Organization, a former president of Inter-American Society on Endoscopy, and a dear friend of us, to introduce the speakers. Okay, Asadur, it's yours.
Hello, everyone. Thank you so much, Leaks. And thank you for this minute of silence for all the people that is suffering around. And all my heart is with the one that suffer and with the people in Venezuela. I was just there with them, and the pain is horrible. So we are all with them and supporting in every aspect that we can. This beautiful webinar that Dr. Lix has been putting together on behalf of the Inter-American Society of Digestive Endoscopy is go around artificial intelligence, as you know. And artificial intelligence is one of the main topics that is putting all our effort, and we need to understand it very, very much more. And in fact, during this World Cup, we have been maybe suffering or maybe cheering the artificial intelligence behind every technology movement. But we never can forget that we must prevail over artificial intelligence and put all our soul to bring the most fair things for our patients and our mates. So let's hear Dr. Fernando Contreras. He's opening with the first lecture. Dr. Fernando Contreras is, as you know, is from Dominican Republic. He has been a former president of the Latin American Society of the Liver Latin American Society, and he has been doing a terrific job in artificial intelligence and also in teaching the new generation of endoscopists during the last 25 years. And I was one of the ones that, like 20 or more years ago, we have a beautiful conversation in a bar here in Montevideo about the things that are coming up. So thank you, Dr. Contreras, for being always there, for supporting us, and being a friend. So please go ahead with your lecture.
Actually, I want to also put my heart with the Venezuelan colleagues and friends that we have seen all the things that happened in Venezuela. And I also want to thank Liz and Jorge for this wonderful symposium and to have the opportunity to share with such esteemed colleagues and friends and brothers like Patrick and Cesare and Dr. Bueno. Well, Liz asked me to talk about real benefit, the quality in colonoscopy and AI, if there is a real benefit or an excuse to train worse endoscopy. And to be honest, I think that debate probably is over in my mind. So I'm also going to talk about AI beyond ADR and trying to move from detection metric to continuous quality intelligence. That, in my view, is the future. And this is the agenda. I basically going to talk a little bit about current data, the problems, the new AI tools, the advantage of those new tools, and the paradigm shift and the role of a future AI in training. I have no conflict of interest. So I really think that the question is no longer does AI detect more adenomas. I think everyone in this audience already knows that it does, and I think there is plenty of data that support that there is an increase ADR up to 25% and a decrease 55% of the adenoma miss rate. But I think the question is, does AI really improve overall examination quality, or does it merely inflate a single metric? The second question that I think is very important is, does AI improve the outcome that patient actually really cares about, like interval colorectal cancer or mortality? And obviously, the third question is, does the training is affected? Could AI automation eventually kill our colonoscopy or affect our training? Well, obviously, there is an evidence gap. I mean, and why detection isn't enough? I mean, why, despite the fact that I showed that it increased adenoma detection rate, the AGA, even though they have recognized there is an 8% absolute ADR rise and maybe 2% of advanced adenoma and serrated lesions, they still do not either recommend or go against the implementation of CAD detection. And probably because there's still very low certainty of evidence for outcome that really matters. The ASCE actually had a panel vote that recommended CAD-E, but that wasn't even a unanimous consensus. And again, they also state very clearly that there's no data yet exists on interval colorectal cancer or mortality. So I think that current AI solves for an intermediate variable, but the clinical goal remains unchanged, which is basically reduce mortality. And I think it's basically, I mean, we all know that colonoscopy quality encompasses a lot more than just the ADR. It really have a lot of domain, and each domain is very important. I think this is exactly the same with image-enhanced endoscopy. It's a fantastic tool, but you have to take care of all of other domain if you really want to take really advantage of those technology, either imaging-enhanced endoscopy or AI. Fortunately, the technology is advancing so quickly that now we have available, and we will have probably commercially available very soon, a lot of other technology that are going to be very useful in measuring the invisible. And that's going to redefine quality metric through computer vision. So we're going to have available in real time and in every colonoscopy cumulative bland area mapping, which tracking exactly which mucosal surface were missed. We're going to be able to assess the withdrawal velocity and the effective withdrawal time, which is more important than the time, the stability of the endoscope, monitoring the center of the lumen and the scope handle in real time. But we are also in real time, we're going to be able to detect how much surface area we're seeing, how well distended the colon is, what the clarity and the preparation. So calculating the percentage of visible mucosa per withdrawal. I always say that what endoscopy is all about is to assess the whole mucosa of the colon. Well, we're going to be able to see that objectively. And also we're going to have objective cleaning score. So that's going to produce reproducible, unbiased pre-adequacy metrics. And all that, when we have all that together, then we're going to be able to have a continuous quality intelligence frame. So we're going to be able to assess the quality of the examination, look at the preparation, cecal intubation, documentation, the inspection quality, effective withdrawal, mucosal exposure, blind spot. We're going to be able to assess the quality of the detection, the characterization is going to get better. And when that gets better, the therapeutic quality is also going to get better. And all of that will for sure will traduce in a better patient outcome. So when we combine the human expertise with its clinical judgment, empathy, with AI augmentation, real-time insights, and consistency, I'm pretty sure that we're going to get where we want to be, which is decrease interval colorectal cancer and mortality. So we're basically witnesses the first generation of AI, which was concentrated in detect lesion, and thanks to that technology, we were able to get outcome metrics. So basically, that technology told us if we did it well or not. But not the outcome, what we saw. The new generation of AI is actually going to give us measured quality while we're doing the procedure. So it's not what we find, but how we examine the colon. Now, hopefully, with this new technology, we will be able to move to predict outcomes, to be able to assess interval colon cancer risk, personalized quality assessment, competency analytics. So basically, for 10 years, we have equated AI with CAD-E. I think that that's no longer true. Detection is only the first chapter of the AI story. And this moving and improving in technology has allowed us to move the evolution or to see the evolution of the colonoscopy quality. When I first started training in 1990, a good colonoscopy is the one who was able to get to the cecum. So the colonoscopy quality was assessed by your rate of getting to the cecum. Well, fortunately, that has progressed a lot, and now we assess a good colonoscopy how well he is able to detect ADR, APC, or serrated lesions. But that's definitely not enough. I think the next step is that a good colonoscopy is the one that can be proved through measured quality how well you did the study. Not what you find is if you really reviewed that colon very well. And so the colonoscopy quality has progressed from completion to detection to continuous quality measurement. And so what I think, the way I see it is that now we have an independent observer, which is AI, that is not only going to tell us there is a polyp there, no, he's also going to be looking at us. He's going to be looking to see if we are withdrawing the endoscope very well, if we are really covering the blind spot, how much mucosa are we exposure, how stable our endoscopy is. And that's going to be documented, that's going to be storage. So for decades, the endoscopy was both the performer and the evaluator of the examination. AI now will introduce for the first time an independent observer that is going to be working all the time in every endoscopy, and it's going to be reviewing every endoscopist. So, and that's going to traduce to a future report. In the new future report, we're going to get a new standard, new report, new area of quality. We're going to get a report that's going to tell how was the quality of the inspection, what was its percentage of mucosa that was exposure, how many blind spots you left behind, what was the stability, I mean, where the scope was in when you were withdrawing, and that's going to be documented. And you're going to even get an AI confidence score. I always tell my patient that if they do a colonoscopy with somebody else, I cannot really judge that colonoscopy because we only see if they find the polyps or not. But I think with this technology, we will be able to really document it or to really see if somebody did a good job or not. So the future report will describe not only what we found, but how well we examined the colon. And moving quickly through another controversy with this training and AI. Well, there is definitely legitimate concerns, and I think Patrick's going to talk a little bit on training dependency. But to be honest with you, I'm sorry, I'm not that concerned. I think the current evidence is that there is no prospective evidence of the skilling, or at least that we can prove that the skilling is caused by the AI. And we have really good evidence, a higher ADR among trainees actively using AI, and there is better baseline lesion recognition. Obviously, we still need expert supervision, and that remains to be essential. But I think the challenge in the future is not whether AI should be used in training. I think it's how endoscopists should be training with AI. And to tell you the truth, I don't see the future of training endoscopists without AI, because AI is going to be such a helpful tool. Obviously, with the first thing that we need to make sure that the fellows or the trainee understand is that high quality colonoscopy involves a lot more than just detection. And unfortunately, a deficiency in any of these other domains reduce the quality of the entire examination. But fortunately, we're going to have available with all the technology, as Adur said, I mean, in football or in Tesla or in the Formula One, there's so many sensors that we're going to have available. And we're going to be able, with the help of the AI, to assess in a very objective way a non-human bias. And we're going to have quantitative data-driven metric in real time, instant feedback to our fellows. And in fact, Patrick actually showed us a few years ago a very beautiful paper where he compared colonoscopy without AI, colonoscopy with CAT-E, colonoscopy with a technology that assessed how well we were reviewing the mucosa, or the combination of both. And clearly, without a lot less technology that we're going to have available, Patrick showed that when we have CAT-E plus assessment of the quality of the revision of the mucosa and the quality of the withdrawal of the endoscope, you get much better result. And I think that's the future. And the good thing about this is that we're going to be able not only to monitor on every colonoscopy and every colonoscopist, but we're going to be able to follow the trainees' progression from the beginning to the end. And we're going to, for the first time, have really very measurable data and how competent a fellow is. So I don't have any fear that AI should be used in trainee, and it's only going to be really valuable. Obviously, the human element will never be replaced. There's a lot of things that AI cannot replace: clinical judgment and scope handling, therapeutic skills, recognition of subtle inflammation, resection strategy, complication management, real-time clinical decision-making, and of course, patient empathy and communication. But I think at the end, even though technology does not define excellence, excellence is defined by the consistencies of quality. I think artificial intelligence will make much easier to make that consistency measurable, and that would allow us to see if we're doing a good job or not. And I think that the future is human plus AI plus quality metrics, and we should be working hand in hand with AI to produce a much better outcome, and hopefully we will be able to show that AI can help to decrease colorectal cancer interval and mortality for colorectal cancer. Thank you very much.
Thank you so much, Fernando. Leaks, you wanna do the discussion afterwards, okay?
Yes, the discussion is the end.
So, so again, Fernando, beautiful presentation. I was just sending in the Inter-American Society chat that superb as always, but it's very interesting, and let's give it for afterwards. But the positive attitude of your conferences, that's beautiful. So now we are moving to Dr. Patrick Sharma. Dr. Patrick Sharma is a former president of the ASGE and also has been leading the current teaching of artificial intelligence. He is a renewed expert in bioesophagus, as you know. And in fact, I'm sorry for seeing it again, but he helped me a lot. So like in 2006, when we were starting with NBI, and so we were able to start with NBI and all the protocols due to him. He was the one that lead in all that journey. So now he's leading in this new technology, artificial intelligence. So let's move ahead. He's just came in from the soccer field. So well, let's move now for Dr. Sharma.
Okay, thank you, Asadur, and for our Argentinian fans, congratulations, and we looked forward to the final. So my congratulations to everybody from Argentina who's on the call today. Fernando, excellent lecture, and I will just move into talking about the role of AI specific for Barrett's esophagus. And one of the challenges, as we'll see, for detection is that a lot of our lesions are very subtle, and the human eye is not able to distinguish between early cancer, could be Barrett's cancer, gastric cancer, colon cancer in the lumen, and that's why we need this. The other thing to recognize from previous data is that we do miss upper GI cancers. And of course, my focus is on esophageal cancer in this situation. So what you see in this study is that the overall miss rate for upper GI cancers during standard upper endoscopy is about 18%. And also to recognize that the miss rate is much higher in the West as compared to the East, and that specifically is talking about Asia and Japan. And also the miss rate is much higher in non-expert endoscopists as compared to expert endoscopists. So wouldn't it be nice if AI could make all of us expert endoscopists and all of us very Japanese so that we don't miss any of these cancers? So, what are the possible reasons that this could happen? I mean, we can have incomplete exposure of the GI mucosa, or the lesion is there and the endoscopist just fails to recognize it, and AI could act as a technique or a tool to alert us and for us to help diagnose and detect more Barrett's cancers. So let's look at it in different stages. It's not just CADI, but different ways that AI can help us. So let's walk through each one of this, that how can it help us to diagnose, to grade it for histopathology and surveillance, and to improve the quality of Barrett's endoscopy. So let's start with initial diagnosis and characterization, which is trying to target these areas. Now, there are different ways of the algorithms that they will help us in diagnosing Barrett's cancer. Here is one technique in which you can see that when you freeze it, the heat map appears on the right lower quadrant, and it helps us in pointing out that this reddened area here is actually Barrett's adenocarcinoma. On NBI, you can see it significantly appears abnormal, and this is how one of the systems can help you doing it. This is another system which was developed by Helmut Mesman and his colleagues in Germany, in which you can see that they have two screens. One is the big monitor, and then when you freeze frame, it gives you the predicted cancer probability. So you can see here is standard white light endoscopy. You freeze the image, you start looking at it, and here it tells you with the heat map that the probability is 0% that this area has Barrett's adenocarcinoma. So it requires, of course, very good technique in which you freeze it, you clean the area, the endoscope or the algorithm is able to detect something abnormal, and the blue bar at the bottom tells you what the probability of that harboring adenocarcinoma is. Here is some automation, but followed by segmentation, in which you can see that the AI is nicely segmenting the entire tongue in blue that you can see. And within red, you can see that there is a very subtle area of Barrett's cancer, which probably even expert could miss. Again, on white light and then on NBI, you can see that it's a flat adenocarcinoma and very well detected with the help of artificial intelligence in it. So what's the evidence that it works? You can see that the evidence pool is very small, 12 studies, about 1,400 patients. And what that showed is that the overall sensitivity of AI and the specificity was very comparable to that of white light endoscopy alone, with a very high area under the curve. Next is, can this also help us predict the depth of cancer when you see it? And there's one study to look at it, looking at images of T1A cancer and T1B adenocarcinoma. You can see that T1A is within the mucosa, T1A goes within the submucosa as well. And you can see that not great numbers, but the AI was able to differentiate between T1A adenocarcinoma and T1B adenocarcinoma, for which currently we require either EMR or ESD to do that. So again, very similar to what you heard from Fernando, this is AI 1.0. In the subsequent images and AI algorithms, this will probably become as good as specimens that we obtained during endoscopic resection. Can AI also be used for Barrett's histopathology? Here's using AI for looking at slides and then seeing how accurate is the computer in making a diagnosis of dysplasia. This involves what's called WSI, or whole slide imaging. The slides are annotated, they're passed through the computer, and you can see that for non-dysplastic Barrett's, for low grade and for high grade, extremely high F1 or accuracy scores, which we would all agree is much better than our pathologists for making a diagnosis of low-grade dysplasia or high-grade dysplasia. So in the future, all the biopsy samples that we are sending to our pathologist will definitely undergo a first look by the computer, which will make a diagnosis first before a pathologist confirms the diagnosis. The second way how AI can help in this situation is by helping us for surveillance based on the pathology. This is a model which was developed on endoscopy reports and pathology reports. So looking at what the endoscopy report said, whether there was a lesion or not, and what the pathology said, what grade of dysplasia the patient had. And so this was combining both of them. And then they trained the algorithm by giving it surveillance assignments, saying that if there is no dysplasia, the surveillance can be extended. If there is a lesion, the patient needs to come in for immediate treatment for high grade or cancer, and then for low grade dysplasia as well. So the algorithm was able to identify patients and assign surveillance intervals with almost 100% accuracy in the internal validation, and that remained true for the external validation as well. So how will this help us? So when you see a patient with Barrett's esophagus, you have your endoscopy report and your pathology report. Right now, both of them don't talk to each other. You send a letter to the patient saying that the patient needs to come back for an endoscopy after X number of years or months or days. Well, what if that is missed? You have now your system or your medical record systems, which can now pull up these reports automatically, find out what the patient is in your database, and make sure that they get reminders, you get reminders, and the surveillance assignment will be highly accurate in this situation. Finally, quality of endoscopy. We heard about that. This is one such software which is available for documenting quality in upper GI endoscopy. So you can see that on the right-hand side, it's the landmarks in the esophagus. These are landmarks and area examined in the stomach, on retroflexion, and the duodenum. And it is automatically capturing images as suggested by the WEO guidelines that 32 images should be taken during upper GI endoscopy. And I know all of us forget to do it. This check mark tells you whether you've examined the duodenum or not, whether the antrum has been examined. So until you get all the check marks, it will tell you to go back, re-examine those areas, and then have a very high quality upper GI examination, which right now, I don't think a lot of the endoscopists do a very high quality examination on upper endoscopy. So, what's next in all of this, I think, will be looking at what the AI task is. So, AI can improve navigation, which is CAD E. You can do CAD X, lesion demarcation, and looking at anatomic landmarks. How does this translate into patient benefit? You can reduce cancer miss rate. It can lead to targeted biopsies, prediction of histology. With lesion demarcation, you can have complete resection of the lesion, and you can have adequate reporting and a very high quality Barrett's endoscopic examination. So again, Azadur and Lix, thank you to you and to Syed for inviting me to this wonderful session on AI, and my pleasure to be here. Thank you.
Thank you, Pratik, for your fantastic presentation. We we all learned too much with your presentations, and Contreras, your presentation is too fantastic too. I chose the right persons. I don't have I have no doubts. And so now. Professor Pratik will be in another meeting, and thank you. Please feel free to leave us, okay? And now I'll call the Dr. Takashi Ueno. He's a professor from Jishi University. It's a fantastic university that I learned too much. I was there 2 years ago, and I thought that they work with AI and chromendoscopy. It's a fantastic. Please, Takashi Ueno.
Um, Thank you very much for the kind introduction. Um, I'm Takashi Ueno from Japan, and now I share the slide. Is it okay? Okay. Uh, Good evening, everyone. Um, Thank you very much for the kind introduction. First of all, I'd like to thank the organizers for inviting me to this wonderful webinar. It's a great honor to be here today. I'd like to share our experience with AI-assisted gastric cancer detection in Japan. In particular, I will focus on the clinical performance of CAD-I, produced by Fujifilm, and discuss whether AI really works in daily clinical practice. I have no conflicts of interest related to this presentation. I'm Takashi Ueno, and I am gastroenterologist at Jichi Medical University in Japan. My research focuses on AI in upper GI, and particularly for early gastric cancer detection. I'm also involved in therapeutic endoscopy, including ESD and POEM. This is background, and Japan has one of the highest incidences of gastric cancer in the world. Because of this, early detection has become one of the most important goals in our daily clinical practice. Over the past decade, Japan has also been at the forefront of developing AI systems for gastric cancer detection. Before discussing AI, I'd like to briefly mention the most important risk factor for gastric cancer. Approximately 85 to 90% of non-cardiac gastric cancers are associated with Helicobacter pylori infection. Importantly, eradication therapy reduces the incidence of gastric cancer by nearly 50%. In addition, since H. pylori eradication therapy became covered by the National Health Insurance System in Japan, the number of patients undergoing surveillance endoscopy has increased. As a result, early detection has become even more important than before. So, why do we need AI for gastric cancer? Although endoscopic imaging has improved remarkably over the past decade. Detecting early gastric cancer remains challenging. Previous studies have shown that many gastric cancers are missed during routine endoscopy, particularly when using white light imaging. Therefore, AI has attracted considerable attention as a tool to reduce perceptual errors and support endoscopists in daily practice. Several AI systems for upper GI endoscopy have recently been developed. Among them, CADI is one of the few that has been evaluated in a multicenter prospective study. Today, I'd like to share our experience with this system. Let me introduce the GCADI trial. Our objective was to evaluate the real-world clinical performance of CADI for detecting gastric neoplastic lesions using both white light imaging and linked color imaging. This was a multi-center prospective confirmatory study. We enrolled consecutive patients with previously diagnosed gastric neoplastic lesions. In total, 162 patients with 174 gastric neoplastic lesions were included in the final analysis. CADI generates both a rectangular frame and a notification sound when a suspicious lesion is detected. We then evaluated the sensitivity of CADI under these predefined criteria. Let me first show the primary outcome. With white light imaging, the predefined threshold was not achieved. In contrast, LCI successfully met the predefined criteria. The higher sensitivity with LCI may be explained by the enhanced color contrast between the region and the surrounding mucosa. Next, we analyzed the characteristics of regions that were not detected by CADI. Using white light imaging, 14 regions showed no AI response. Lower sensitivity was observed for anterior wall and regions smaller than 10 millimeters. In contrast, LCI showed no response in only 6 regions. Importantly, LCI achieved a sensitivity of over 90% across all evaluated subgroups. Why did CADI miss these regions? One possible explanation is that CADI depends on adequate region exposure. Under optimized conditions, previous offline video studies demonstrated a sensitivity of over 90%, even for difficult regions. However, in real-world clinical practice, region exposure and viewing angle are not always optimal. Therefore, AI performance depends not only on the AI system itself, but also on adequate region exposure and careful endoscopic observation. We also evaluated newly identified gastric neoplasms. The sensitivity was lower than that for previously known regions. Most newly detected regions were very small and located on atrophic mucosa. These regions were simply more difficult to detect. Therefore, CADI should be considered an adjunctive tool rather than a standalone screening system. Although CADI showed promising performance, one important challenge remained. Version 1 frequently generated false positive alerts. Reducing unnecessary alerts is essential for improving the usability of AI during routine endoscopy. To improve CADI, the deep learning training dataset that was expanded by approximately 1.6-fold in version 2. Based on this updated model, we are currently conducting a sub-analysis of the GCAD trial. Our goal is to determine whether version 2 reduces false positive alerts compared with version 1. We believe this represents an important step toward more practical AI-assisted endoscopy. Um, this is a 10 millimeter type Del2C region located on the greater curvature of the antrum. As you can see, CAD-I responded only to the neoplastic region and did not react to the surrounding intestinal metaplasia. Although this is just one of representative case, it suggests improved lesion recognition with CAD-I version 2. Finally, I'd like to introduce our ongoing research. We are currently conducting a multi-center prospective study using ultrathin endoscopy together with CAD-I version 2. Compared with conventional endoscope, ultrathin endoscopy offers several important advantages. It reduces the gag reflex, causes less discomfort, and can usually be performed without sedation. These features make ultrathin endoscopy an ideal platform for gastric cancer screening in Japan. We hope that combining ultrathin endoscopy with AI will further improve the quality of gastric cancer screening. This new ultrathin endoscope uses an LED light source with improved brightness and image quality. We hope that the combination of ultrathin endoscopy and CAD-I version 2 will further improve gastric cancer screening. Before I finish, I'd like to return to the title of today's presentation. Does AI really work? My answer is yes, but AI alone is not enough. AI is a powerful partner, but the quality of AI still depends on the quality of endoscopy. Therefore, the future of gastric cancer diagnosis lies in the collaboration between AI and endoscopists. Thank you very much for your attention.
Thank you very much,
Thank
Dr.
you.
Bueno. Beautiful presentation. And thank you for making your university so important for all of us. I know that your university was created to teach in Japan, but obviously goes far away from Japan and it touch all of us here in the Americas and beyond. So congratulations for that, and thank you for this beautiful presentation. I think you all three open the door to a very, very nice conversation right now. Lix, what do you think?
No, I think it's very impressive. Thank you, Ueno Sensei. Uh, Great presentation. And as always, the, because I think we learned too much in this webinar. Unfortunately, we don't have today Cesare Hassan that could not be with us, and probably a problem with communication uh, for me, and he didn't send me. I thought that he didn't send me his presentation, and I didn't prepare um, anything for replace because it is impossible to replace Cesare Hassan. But I want to present something only to stimulate the discussion. And please, when I'm talking, send questions. Uh, uh, we read the questions and I try to answer. Okay, then I will share my slides. Uh-oh. Waited just a little. Is okay?
Yes.
Uh, 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 I put the title of the Cesare Hassan, but I put now because I didn't prepare. But I'll try to tell something about AI that I want that people uh, stimulate their discussion. We only have to trust in our eyes when you talk about chromendoscopy, magnifica zoom endoscopy, and we know has a big difference in my eyes than from other eyes and the Japanese eyes. And then we, especially for colorectal cancer, we still have PCCRC until 10%. It's very, very, very high and it's not good. And we have a lot of things to for us to get better. But most of these technologies it depends of the endoscopies, the human being. And then AI came to try to support us in any part of an endoscopy before the patient should do the colon preparation and the quality of endoscopy and to the metrics of endoscopy and colonoscopy. And I think it will be, we can don't look for AI. We have probably it will be the future. We work together with AI, and we have a lot of things that can have problems when we talking about we are human beings. We have many fails, loss of competence, loss of attention, or we accept the basic symbiotic and loss of competence, and this probably lead us to missing lesions, inappropriate approach for the lesions with cost duplications, inadequate treatments, and we probably have too much interval cancer if we don't have more types of technology to help us. And here and only show that removing a small polyp with a forceps. Uh, then after we are putting the specimen in, to centrifugal histology, and we are not fixed, but the AI look for a small lesion there. And I think this is important to know because the human being cannot be always looking for the colon all the time. And we have a lot of papers talking that AI is more accurate than another technologies. And but here is another example. We are in the column using AI. Well, everybody saw the lesion, but AI didn't see it. Then that's why we have to work together, not only I. Now you can see the lesion, and now AI is trying to read the lesion, and then we can. The AI told that it's hyperplastic, but it's not hyperplastic. You can see that small adenoma when using acetic acid plus zoom endoscopy and BLI. And we have papers say that AI keep the P, PIVI thresholds to use the strategy of resect and discard and leaving in place. And it's very good because the costs are too much less when you don't have to use the pathologist all the time. And we have a lot of papers that we are progressing to the years here 2023 for Hassan and all that say that you can use using European Society criteria or American Society criteria to live in place and discard. And another paper say that no experts with AI have the similar performance of experts. That's very nice. And the European Society uh, accept the AI if you have met this criteria. And now the characterization of colorectal neoplasms is very important because there are several reasons that if you don't have the right diagnosis, you have problems. Choosing the right treatment strategy for the lesions when you have to use in block resection and reducing unnecessary medical costs and to choose endoscope or surgery because you can do a over treatment or under treatment. That's very it's terrible for our patients. And with so the JNET classification, especially when you JNET 2B, it's not very good, very accurate. And the many papers show us that's not a very high accuracy when for 2B. And this is a paper that Professor Tanaka presented, I think, 2 years ago in European Congress. And he showed that we can use AI to use JNET and NICE classification. And the JNET, the AI can achieve the same results from an expert. And he concluded that with KDI may contribute to education for non-experts and assist in diagnosis colorectal lesions and facilities where the use of magnifying endoscopy has not been standardized. And as showed Dr. Contreras, in many a lot of things we can AI can improve our quality of our procedure, detecting more adenomas and the adenomas muse rate getting better. But uh, this success rate lesions, it's not very good detection for AI. Then that's why the importance of that we have to work together. And I don't know if you showed this video because I think the discussion is important. And here is a message of the who developed artificial intelligence in cancer prevention. It's one of the experts in the world, and he said the people tend to worry that AI steal their jobs, but I think the AI as a member of the team, something complementary that could eventually free up uh, of care of humans, as say Dr. Ueno. This first paper uh, get us crazy because we think if you're using AI for a time and when you remove AI, your ADR doesn't improve. Uh, it's the term of the skilling. But after this paper, another papers, here's a slide from Dr. Cesare Hassan. There's papers that here is 2025, 2026 that we don't now we don't know if you have upskilling, deskilling. It's not proven. And here I present that we are using AI for quality metrics in colonoscopy. That's it's a doctor from Rio de Janeiro, Dr. Fernando Castro, that developed AI, and you put your you put in your clinic and you have daily your performance and for other doctors that work with you and the all team together. It's very metrics of a quality endoscopy. It's very, very nice. And I'm telling this because we have to develop AI in many situations in endoscopy. And here we beneficial AI likely, especially in an experience. That's a conclusion of Cesare Hassan. The skilling and upskilling effect is uncertain. We don't know exactly because it depends of the tempo, the time of the exposure, the level of experience of the endoscopist to have upskilling or deskilling. But the limitations, especially in my country, you don't have talking anything about payment. The different AI and deep machine learning models are evolving. There's heterogeneity of differential models and training data. Prospective independent validation is required for each system that you're using. And long-term results are not known. Does PCCRT change? Probably, but we don't know. We have to wait more 15 years to have this answer. But uh, I don't have doubts that if you use like a team AI as a second endoscopist and working with you together will be the best results. And I like always this message, it's not the strongest of species that survives, nor the most intelligent, but the one most responsive to change. And we have to have our feet on the floor, but look for the future, our eyes in the future. And now, please send your question for discussion. Thank you.
Thank you so much, Leaks. Let me open the chat so we can follow the questions that you are all invited to submit.
I'm looking. We don't have questions in chat until now, but I had a question, I think for all of you. When the AI starts in the endoscopic practice, we thought that we will have changed many things. The AI will replace chrome endoscopy, and you can have your normal endoscopy. It's not true. You don't need high resolution endoscopy. You don't need BLI, NBI, LCI, TXI to have the diagnosis. And because with you're talking about costs, and now I want your opinion. If you can use AI, Dr. Ueno uh, told us that he used LCI is better than white light when using AI. But do you think the future of AI, you will not use more chromendoscopy or other technologies to have the right diagnosis, or we will still need this technology?
Oh,
Dr.
okay.
Bueno first.
Um, Thank you for your question. Um, so I think um, chromendoscopy and um, some other image enhanced endoscopy is needed because AI is uh, not completely. Um, so AI is uh, just valuable adjunctive tool for cancer screening. It should support, not to replace endoscopists. Um, so high quality endoscopy remains the foundation of accurate diagnosis, I think.
Thank you. Contreras?
Well, my feeling is that image-enhanced endoscopy, it helps not only to us, but I think it helps AI too, because I mean, after all, AI learns from repetition of imaging, and no question in my mind that either LCI or MBI or BLI and magnification improve the quality of the imaging. So I think AI can take advantage of that, and it will give us a much better and more precise diagnosis. And I think that that topic of characterization is so important. And I think that when we work together with AI, not only my hope is that we're going to save a lot of money because and probably this will set off some of the off cost of the AI, because if we can prove that with the imaging enhanced endoscopy and AI, we can discard so many biopsies that we send to pathology today, that we waste the money. Because I mean, I always tell my patient that I know more or over 90% of the cases of the polyps that what the pathology is going to tell us. So when we reach to that point, I think the saving is going to be so much that we can actually afford to buy the equipment.
Thank you.
Well, you are introducing a very interesting topic. We will need another symposium for that topic. But that goes by hand with a couple of questions that are coming through the chat. And they are asking about the cost and how we can solve the problem of the cost in the region, in our region, that we are not making any assessment and we need to buy it right now with the money that we have. And I think I understand this question. And the point is that, is there anything in our region that we can develop in order to afford in a much more efficient way, or the cost that they are right now are the cost that they are, and we need to assume that cost as a more costly procedure in the near future? I think that is part of the question is coming, and I will add that what's your perception? This technology is gonna keep this price as a new standard for the price of endoscopy, or this is going to with the improvement of the technology is a cost that is gonna be lower in the future?
Well, I'm actually afraid that the cost will probably not going down that soon, because I think the movement of the technology is going to add more tools to the AI, and not only that's going to happen, but I think that's going to be very important. And the question will be, when you have all the technology integrated in an endoscopy in the tower or to the endoscopy, that you can. I think we are going to get to a point where the technology is going to be so important, because it's going to judge every endoscopy and every endoscopist. And I think that most unit will require, or even the insurance will require, that you have this technology so that they can judge your work. I mean, I think that's the future. But how long it's going to take? Probably it's going to take a lot, because of the cost and because of our environment can't afford that, at least now.
So excellent. So now also goes in my hand with some other things that they are introducing here, and is that it seems it's gonna not be a standard in the short term, because if we cannot all afford, we cannot assume that that is a standard. And I am thinking before, when we change from standard definition to high definition, nowadays we all use, I think, high definition, and it's a standard, and that it doesn't make a high cost. For example, you take an iPhone. The iPhone it keeps more or less the same cost, but each generation is a bit better. So, but in this case, there is something that is a new generation but brings the cost up. So, how do you think this is gonna move in the next years? Dr. Güero, for example, in Japan, what is happening with all of this?
Um, um, I'm sorry. That's the
The
difficult question.
cost,
Yeah.
the cost in the short
Yeah.
term, to make it simple.
Um, and in Japan, um, so endoscopic screening is um, for the medical checkup and after follow-up education pylori, for pylori. So uh, uh, health I using health insurance in Japan. Um, mm, the cost is uh, an, not so problem. Um, I'm sorry. um,
No, so in
this
Japan,
this is
this
difficult question. Yeah.
is covered by the insurance, all
Yeah.
the equipment. Okay, that's the point. That's the point. Okay, thank you.
Ambassador,
Yeah.
uh, I think the AI, I'm talking for column AI. I think if in the future we can prove that AI, especially for screening programs, help to put all endoscopies more or less in the same level, it would be very nice. And then probably reduce the costs because if it the great problem, like in my country, we have a large country and few endoscopies and you have to prepare the endoscopists to participate in the this program. But they don't have experience, they don't have quality endoscopic parameters, nice. If AI can give for these endoscopists more or less the same level of the experts or near the experts, I think it will be very nice with less cost because you can use the extraterritorial of the resectants cards and live in situ, and then the cost of AI it will be not too much because you prevent too much more colorectal cancer. But we have to prove this. We have to, yeah, no, you have to wait. I told uh, 15 years to have this answer.
Yeah,
One of
but
the
the other thing, I'm sorry, Jorge, is that, I mean, if the prediction comes true that in the report, in 5 years, 10 years, in the report, you will have the assessment of how you did your endoscopy. If that become a standard, then it's going to be very difficult not to have this technology. I think at the end, probably it will be a trade-off. I mean, I think cost will, as you say, probably the units or even the endoscope company would need to be adding this technology, and I don't think that they're going to increase that much as with technology because it's going to be for sure it will become a standard that the all endoscope would need to have all this technology so that you can actually have the at that moment the standard report and where they analyze your job.
Yeah, Asadu, I think we are in time. I went to Ueno and Contreras and Asadu. Can you leave us your message about AI for youngers that are beginning to work with AI? What they can expect from AI in your view? Well,
Yeah,
Ah,
please, Dr.
a message.
ah, okay. My take-home message is that and AI is really valuable supporting tool. But uh, so younger endoscopists need to train um, the endoscopic skills because high quality endoscopy um, remains the mm, foundation of accurate diagnosis. So AI is mm, not only supporting tool, I think.
Thank you. Contreras.
Yeah, I agree with that, Dr. Ueno. And I also think that AI is a must, and it will become even more important every day. And I think the not only the trainees, but all the young people, but also any gastroenterology in practice should get into what AI can do for them. I think AI as a whole is here to stay. So either you go into and got on that train, or you move away because it's gonna blow you away. So I think we have to accept that AI as a tool that is only going to be helpful if we do it, if we take it and use it the right way.
Thank you.
Wow. So this is, I think, is a fascinating topic. And first of all, there are coming some more new questions, but I am going to write it down and share it with leaks. And I think there are topics for the next symposium because we cannot end this discussion just right now because it's just too many things to talk on. But just for finishing, I think that an important point of all these new technologies is gonna make us closer. It's gonna make it's gonna bring equity. Also, they are going to to make us being more in more distance. It's gonna make bring not non-equity in our practice, and that's, I think, is the problem. And I think it's a problem for our region, a big problem for our type of region, because as Dr. Bueno shared, in Japan everything is under the system and the system pays for it. But here that is totally different, and cost is always a matter. And I think that I will share something that I am 100% sure that is the same situation all around the Americas. Here we focus on today's price, what we need to pay today. In our region, we are not making an assessment of cost for 1 year, 2 year, 5 years, and saying, okay, we are investing this and this is gonna save money. For example, no one is building a highway, in order to see if the fuel consumption in going at 80 kilometers per hour is gonna be less or not. No, they are saying how much money I put in the tank today. So that is the point with artificial intelligence, how much money I'm spending today. So we need to work. This type of webinars and introducing the topic are very important, and we need to talk more from our societies and exchanging and bring ideas closer, because like a doctor says a lot of time ago, about quality. If we don't, he said, if we don't do that, someone else is gonna do it for us, and that option is not gonna be nice for us. So we need to take action. So we need to work on, and we need to, have a posture from the like from the Inter-American Society, hopefully from the World Endoscopy Organization. We are already taking some postures in some aspects, but we need to both protect the patient, but also protect our colleagues and ourselves. In the point that doesn't turn against us, if not work with us. That, I think, is the most important thing in the short term.
Uh, Thank you, Asadu. Thank you too much, Contreras and Ueno Sensei. Fantastic webinar. I want only tell you before finish, we are preparing a questionnaire to send for all members of CIED and other people to answer questions about AI, and you can give your opinion and then we will prepare a paper for what CIED thinks about AI. And please come to CIED, everybody, and help us to have a right opinion of Latin American what thinks about AI. and we are together with WHO. And thank you so much. Contreras, you want to
And I make just a final message, just for those people that Jorge is talking about that cannot afford AI, they must remember that quality endoscopy can be done without AI. It's a matter of decision to do quality endoscopy. So you don't have to have AI to do quality endoscopy.
Thank you. Thank you, everybody. Bye.
you very
Bye.
much. Thank you. Thank you.
Thank you.